welcome back. Well, today I am joined by Dr. Linda Chan and Dr. Eric Passon, who are here from Saddleback Medical Center. Dr. Chan is a medical director of radiation oncology, and Dr. Eric Passon is a urologist at Saddleback Medical Center. Well, welcome both of you. I appreciate you taking the time.
Thank you for having us.
You're welcome. Now, Dr. Passon, let's talk a little bit about prostate cancer and when do men need to start getting checked?
So it varies across the board somewhat. For men who have no family history of prostate cancer, no first degree relative of prostate cancer, we typically start screening them at the age of 50. African American men who have a higher prevalence of prostate cancer in the population, we usually start screening at 45, and men with first degree relatives, whether that be a father or a brother with prostate cancer, we start at the age of 40.
Okay, so that's a 10-year difference. Do you vary from that? Meaning, at what point would you go even younger?
Interesting you say that. It brings up a patient that I diagnosed at the age of 37 who had a family history of prostate cancer. And he had seen someone who said, you know what, you're outside of the recommendations and we're not going to even screen you. And he came to me and we got a PSA. His PSA was elevated, and we'll talk a little bit about what PSA is in a second. But his exam was normal, and ultimately at 37, he had an aggressive form of prostate cancer. So to say these are clear-cut guidelines that should be followed, I think there's a gray area in there, and really a discussion with the patient is important and what they feel comfortable with.
Exactly. And then you did lead into testing. So my next question was going to be about testing. So what kind of tests are available today for folks who either think that they have prostate cancer or they do have prostate cancer?
Well, unfortunately, in this day and age, and we think, wow, we're in 2020, we should have a lot of uniform tests that can determine if someone has prostate cancer. We don't have that type of test. What we use is the PSA, right? The PSA stands for prostate specific antigen. And when you think about the name, it's very appropriately named. It's a protein found in the blood that can be detected by just a simple blood test that is very specific of what's going on with the prostate. So when it's elevated, something is going on with the prostate. Not the liver, not the lungs, not the brain. None of those organs create this molecule. The problem is in detecting prostate cancer is benign conditions and prostate cancer can raise the PSA in the blood. So that blood test coupled with a very common exam, just a prostate exam or the digital rectal exam, to feel the contour of the prostate. Is there any abnormalities of the prostate? Is there any nodularity of the prostate? These are the two mainstays of screening and testing that we use to determine prostate cancer.
Okay. Do you think there's anything down the line that might be better? Have you heard of anything?
There are a lot of adjunct tests that I use in practice, aside from the PSA and aside from the exam in suspicious men. Kind of many different tests, the 4K score, multi-parametric MRIs. These types of tests can further enhance the ability to detect prostate cancer, but there's not a clear, wow, when this test is elevated in the blood, it means you have prostate cancer. There's kind of the art of the diagnosis as well as a discussion with the patient and when, if they even want to be screened. So all this is important in the dialogue and coming to a conclusion about who to test and who to screen and who to diagnose.
Okay. All right, good. And then let's talk a little bit about some of the symptoms that men might feel or notice.
Absolutely. Fortunately, with the advent of screening, we rarely see symptoms of prostate cancer. And that's fortunate because when symptoms arise from prostate cancer, oftentimes it has spread, it has metastasized. So organ-confined prostate cancer, which is by and large what we routinely find, is pretty much diagnosed by PSA elevation, maybe an abnormality on exam. It's the metastatic cases, or the cases where there's either locally advanced disease or spread of disease, which cause symptoms. Bone pain can develop if there's spread of prostate cancer to the bone, and prostate cancer has a predilection of going to the bone. Ureteral obstruction can develop as well if a lymph node becomes encased around the ureter, and people have much similar symptoms as like they're passing a stone, right? A little very colicky pain. So when we talk about symptoms of prostate cancer, rarely do we see someone coming into the office that we diagnose with symptoms of prostate cancer. It's uniformly by an elevated PSA or an abnormality on exam.
Okay. And I know you work very closely with Dr. Chan. Can you tell me at what point do you refer your patient to Dr. Chan? Absolutely.
So once the diagnosis of prostate cancer is made, and that typically happens after a prostate biopsy, depending on the aggressiveness of the cancer, we do a staging evaluation. And I'm a firm believer in a multidisciplinary approach towards the treatment of prostate cancer. I myself am a surgeon, so I do a lot of prostatectomies, but men have to hear the radiation side of it also, because it's a fantastic curative modality for prostate cancer as well. So I will routinely refer to Dr. Chan for a radiation consultation, and then we work in coordination and hand in hand in mapping out the best option for the patient and what they want.
So Dr. Chan, once a patient comes to you, what do you do for them?
So when a patient comes to me, then I do a thorough evaluation of their history. I examine them again. But then I think the most important thing is that we launch into a very robust discussion about all of their treatment options. So like Dr. Paston discussed, he'll talk about surgery as a potential option for the patient where the prostate is physically removed from the body. And then I would talk about the 5 different radiation options that a prostate cancer patient might have, and a detailed description of each one, the pros and cons of each, the side effects, and then at the end, which treatment recommendation might make the best sense for that particular patient.
Now, your offices are in separate locations. So Dr. Chan, you are located in the Saddleback Medical Center. Where in the hospital is that?
So that's interesting. We're actually not physically in the hospital. We are adjacent to the hospital. So we're in the MemorialCare Cancer Institute, which right now, especially in this COVID-19 era, is a blessing because we have a dedicated parking lot directly outside of our department. So patients can park for free right outside our front door. And we control the entire space, so there's robust screening, temperature screening of all the patients, and we try to protect everyone from accidental infection.
That's great. That's good news. Let me ask you something. How is prostate cancer treatment evolved in terms of research, protocols, as well as clinical trials?
Yeah, so there's a lot of movement in research for prostate cancer, obviously because it's one of the most diagnosed cancers in gentlemen, unfortunately. I think within the radiation sphere, I'm proud to say that we are offering a prostate research protocol, something called stereotactic radiosurgery. Now, even though the word surgery is in the name, there's no cutting involved, so I'm not encroaching on Dr. Paston's territory, but it's basically an invisible, almost like a laser beam that comes in through the patient. He doesn't feel anything, there's no pain, there's no sensation at all, but the radiation is delivered over 5 days. Oh. Now, this is a big advance in prostate treatment because traditional prostate radiation was given daily over 9 weeks, so 44 treatments. So to compress 44 treatments down to 5, where each daily dose is larger, but still reducing the risk of collateral damage and side effects, is a big advance in prostate treatment, in my opinion.
Now, tell me about the side effects of that particular treatment for 5 days. Are there side effects?
There are not that many, but there are a few. So gentlemen oftentimes feel a temporary sense of fatigue. It's not long lasting. It's always temporary. The fatigue is also not debilitating. So most of my gentlemen are still working full time, playing golf, enjoying their normal life. There's also a risk of temporary irritation to the bladder or to the rectum, such that they're going to the bathroom a little bit more frequently or a little bit more urgently. But again, that's usually temporary and resolves after a short period of time.
There's been something really great that's come out of all of this is telehealth.
Yes. Thanks to the COVID era, we are utilizing telehealth as well. I prefer, instead of a video, you can see I'm not very up to date on these Zoom calls. So this is really the first time I'm doing a Zoom. I normally just get on the phone with my patients and we talk and go over their history and go over what symptoms they're having. And if we absolutely feel we need to bring them in, we bring them in. But yeah, I think it's something that in this day and age where we need to utilize to keep people safe and healthy from COVID. So we do offer telehealth and telehealth conferences as well.
Okay, great. And Dr. Chan, how have you used it?
So we've used telehealth throughout our whole clinic. So the patient has the choice of either still coming in person for a physical exam and an in-person chat, but alternatively, more and more patients are more comfortable doing a Zoom video chat similar to this. Or if they don't have the technology or the access, we also do offer telephone visits, but we do consultations, follow-up visits. It's actually amazing what you can do through telemedicine, but really to protect them so they don't have to come physically into the clinic.
Yeah, there's been some amazing advances in it, and there's a lot of different programs out there, not just Zoom. But anyway, nonetheless, thank you both for being with us. I truly appreciate it. And we will have you guys hopefully in the studio soon enough, okay?
You're welcome very much.
Thank you for having us. Yes, thank you so much.
And we'll be right back after this.